Hello, and thank you for joining the Illuminating Immunity Light Photobiomodulation versus COVID-19. I'm your host, Dr. Joe Doduro. With me today presenting is Dr. Soheila Mokmeli. She's a senior medical researcher and medical laser therapist. She's the education administrator and laser therapy instructor at Canadian Optic and Laser Center, Cole Center in Victoria, British Columbia, Canada. She served as a mentor and counselor for more than 1,000 medical nursing students and has taught and counseled MDs for academic and research projects. She's authored over 50 research articles and 8 books about the application of laser therapy in health and cosmetic subjects. She has received the award for Best Research Study from the European Medical Laser Association and also the Pioneer in Photomedicine in Iran in 2012 from the Medical Laser Association. Their current project is the evaluation of the effects of laser therapy in the treatment of COVID-19 and its associated side effects. I'm very happy to have you here with us today, Doctor. Thank you for your time.
Hi, Joe. Thank you for having me. And I'm very excited to be part of this summit and introduce our papers.
And you've really had a blitzkrieg. You've really been doing a lot of work recently, but your knowledge of laser therapy has gone for over 2 decades. What made you make the connection between, let's say, the COVID pandemic and laser? What was your motivation, if you would?
So let me talk about the background and how this idea came to me. I'm an anesthesiologist and I have years experience working in ICU and working with ventilator. And I also treated patients with respiratory disorders by laser therapy. And when this COVID pandemic happened, we faced with lots of patients and hospitals overwhelmed with patients, and we were short of ICU bed, ventilators, and all of the research showed that COVID-19 is extra inflammation over respiratory tract. And I believe any person who practices laser therapy is familiar with anti-inflammatory effect of laser. And when you put this together, you think, okay, why not using photobiomodulation therapy or laser therapy in COVID patient? So considering this background, my work in the ICU and working with laser over respiratory tract, and moreover, I had presented a clinical trial study in World Conference in 2008 about the evaluation of low-level laser therapy in combined with conventional treatment in patients with asthma. And our study showed that patients who received laser therapy added to conventional treatment, they improved faster, healing process was better, their symptom reduced quickly, and they needed less amount of medication compared to people who just received conventional therapy. So when I put this together, I came up with this idea, so let's dig more and find the connection between photobiomodulation therapy and COVID-19 pneumonia.
Yeah, so you had a magnificent settings. I mean, there's not too many people who have access to the ICU patients and laser therapy. That was a huge hurdle, wasn't it, to overcome? I mean,
based on my experience, I believe I had that skill to combine this together and worked and see the results or improvement. And after all of these process that going all the world, I know there are researchers looking for a solution because right now there are people dying and everybody thinks how we can get back to normal and we can save the lives. And I strongly believe photobiomodulation can be a solution, but we need to prove that. We need to do more research, find more clinical trial, and join together to find out if this modality is a solution for this COVID pandemic.
Well, with that, I think we should go to the slides. Laser therapy or photobiomodulation therapy in COVID-19. Proceed.
Okay. So I discussed how this idea came to me, and I decided to dig a little more and find out if we can use photobiomodulation therapy in COVID-19. And as I mentioned, I presented a research study, a clinical trial in a World Conference 2008 about the application of laser therapy added to conventional treatment in asthma patients. And because of the positive results that we showed in that article, I decided just go and find out more what's happening there. And when you review the research, you see the main problem with COVID pneumonia is hyperactive immune system and lots of inflammation in respiratory tract. And we know photobiomodulation therapy has significant anti-inflammatory effect, and it's confirmed by meta-analysis. So you need just put this puzzle and these pieces together. So what I did, I reviewed the pathogenesis of COVID-19, and then I reviewed the effect of laser therapy on respiratory tract and ARDS. And with help of one of my co-author, Mariana Vetrisi, we wrote a commentary article, and we submitted this article to Canadian Society of Respiratory Therapy. Why I choose Society of Respiratory Therapy? You know, respiratory therapists, they are long expert, and they are fighting in front line with the battle of COVID-19, and they know different modalities, but I believe they are not familiar with photobiomodulation. And if we want to break the barrier, just collecting and connecting people who know about laser, it's not that much progress. We need to go to other people who involved with this battle and introduce this modality. So that is why we decided to submit this article to this journal, and this journal accepted and published this study and paper in July 21st, 2020, after several steps of peer review. So what are the topics that we discussed in this paper? First of all, we started with introduction to laser therapy and photobiomodulation from the basic. It is easy for other people who practicing laser therapy just make a quick refer, but here we needed to explain everything from the scratch. Then we reviewed the pathogenesis of the COVID-19, and we discussed the effect of laser therapy in lung tissue and ARDS. And based on my experience, I designed a protocol and the treatment therapeutic method that I used before, and I made it available for any practitioner who wanted to practice laser therapy for respiratory tract. And I believe this protocol is practicable with any kind of laser set, doesn't matter class 3B or class 4 laser safety, and it is available open access for everybody. And also we discuss about the benefits, possible side effects, and contraindication to just have whole picture and introduce this modality with different aspects. So let's talk about pathogenesis of COVID-19. I'm skipping the part of introduction because I believe people who participate in this summit, they know about all of these basics. So if you want to win a battle, you need to know your enemy. And our enemy here is COVID-19, the small virus named SARS-CoV-2. So what happens there is that this virus attached to a specific protein named angiotensin convertase enzyme, or ACE2. So you can find this protein on the surface of whole cells in respiratory tracts. Not only in respiratory tracts, you can see in other tissue and organs like kidneys. So what happens when this virus attaches to the cells, it penetrates and enters in the cell, replicates itself and produces more virus and produces cytokines. And all of this process kills the cell. And then dead cells flow down to the lower part, lower respiratory tract, and block the airways. This is the stage patients show symptoms like shortening breath, difficulty in breathing, fatigue, fever, tachypnea, cough. And at this stage, our immune system recognizes, okay, there is an invasion, there is an enemy, and it starts fighting back. And what would happen, about 80 to 85% of patients, actually, they can win the battle. Their immune system responds perfectly well, clears dead cells, virus, and during 2 to 4 weeks, these patients improved and healed. But over 15 to 20% of patients, actually, they are not successful in their battle. It means their immune system responds and reacts differently. And immune system goes wild and active crazily and produces more cytokine. More cytokine causes more inflammation. More inflammation leads to more cytokine. And it looks like a blind loop working on and on. So what would happen at this stage? We have lots of inflammation there, and also there is vasodilation and increasing permeability of the vessels, and lung get filled with fluid. And at this point, when you have chest X-ray, you face with white lung, a lung filled with lots of fluid and inflammation. And this is the stage named cytokine storm. And it leads to acute respiratory distress syndrome and death. So this is the third stage of this pathogens. So morbidity and mortality of COVID-19 directly relates to the activity of our immune system and the level of cytokine in our blood level. So when we measure the cytokine substances in our blood or patient's blood, if they are high, it determines which patient need to be hospitalized, which patient need to be admitted in ICU, and which patient need ventilator. The whole procedure and whole of this reaction starts with alveolar macrophage activation. Alveolar macrophage actually is the main pathogenous in COVID-19. So in this figure, I'm going just have a quick review on all of three stages. So as you see, this is the first stage, and this virus attaches to ACE2. Then it enters through the cell, it starts replicating and producing cytokine, and also it activates the macrophage. Activated macrophage works like an alarm for our system. So it sends alarm to immune system and says, okay, there is an alien, there is an attack, and we need to come together and defend our body. So what's happening there? Activated macrophage sends signals to other immune cells like T cells, more macrophage, and more neutrophils. And all of these producing more cytokine and trying to clean the area from dead cells and virus. And as we discussed, this is the second stage, and this stage patient shows symptoms, and 80%, 85% can win this battle and clear the lung and heal. Unfortunately, we see 15 to 20% of patients, and mostly with underlying disease or impaired immune system, they can't recognize exact pathogen and they attack lung tissue, and the damage of this active immune system or exaggerated immune system actually is more than the real virus. And this is the third stage that leads to cytokine storm and acute respiratory distress syndrome. I specifically would like to talk about a receptor here, P2X7 receptor. This receptor has a key role in cytokine storm. This receptor activates by extracellular ATP, adenosine triple phosphate. And we know adenosine triple phosphate or ATP should be inside the cells, not extracellular. But when cells die, they release ATP into interstitial. And this extracellular ATP activates this receptor, and this receptor starts a cascade of chemical reactions, and it leads to producing more cytokine and chemokine. So there is a key role for this receptor in cytokine storm and COVID-19 pathogenesis. So based on, as we discussed, based on the amount of the cytokine storm in blood, the most recent research studies categorized and classified COVID-19 patients in two groups: mild to moderate symptom patients who require just hospitalizing but not ICU, and the severe symptoms and higher level of cytokine level that they need an ICU admission and a support of ventilator. In the right, you see the diagram that explains what's happening there. I'm sure other speakers talked a bit more detail about the procedure, but I want to summarize everything quickly, just keeping in mind what's happening there. So we have the virus attacks alveolar cells, sends inflammatory signals, activate macrophage produce cytokines, and it activates and sends signals to more immune cells like T cells, neutrophils. It increases capillary permeability. This vasodilation leads for more cells there. Actually, they are sending more soldiers to the battle. And we have more expression of P2X7 receptor, that is key point in cytokine storm to producing lots of pro-inflammatory and inflammatory chemokine and cytokine. I am sure you are familiar with all of these terms. I'm skipping that part, and at the end we have destroying alveolar epithelial cells. So if we want to fight with virus, to wind this process, we can interfere at several levels. We need to block these inflammatory signals in some points. That is why right now you see there are lots of research about different antagonists against cytokine, like interleukin-6 receptors antagonists or interleukin antagonists, or there are other medications that they are working against of these cytokines. And what if we have a modality could work and affect this process at multiple levels, not just against of one cytokine or a specific cytokine? And based on our review and research and lots of human experimental level and evidence, photobiomodulation therapy, it can be that modality. So let's see what's happening with low-level laser therapy or photobiomodulation on ARDS. Laser therapy is effective against cytokine storm and ARDS at multiple levels. And it also boosts healing process and tissue regeneration. And all of the effects reached at two levels, local and systemic level. And based on the experience and the studies that we have with chronic obstructive pulmonary disorders over COPD and asthma, we see that anti-inflammatory effect of photobiomodulation can be applied and added to conventional treatment. And murine models of acute inflammation of airway and lung show that when we use low-level laser therapy, it decreases the pulmonary microvascular leakage. And here's 2-point information that you can collect over 14 research studies, experimental research studies on animals, that laser therapy, specifically, it can upregulate interleukin-10. Interleukin-10 is a cytokine synthase inhibitor factor, and it then regulates P2X7 receptor. And we discussed that this receptor is a key receptor in cytokine storm. And also, studies showed and confirmed that low-level laser therapy decreased collagen deposition and scar formation in lung tissue. Patients, when win the battle or pass the process of recovery time, is not just recovery. They recovered with lots of sequels. And it is possible to apply low-level laser therapy and improve the healing process and have less and minimal sequel over lung and respiratory tract. So all of the information and all of the discussion that we make here, we have the references, and we mentioned all of the references in our paper, and anybody want to review that, they can go through the references and find point. In this slide, I put the puzzles and pieces together. And based on all of this research, this is what's happening with low-level laser therapy on ARDS. So light or laser energy can be absorbed by photoacceptors in mitochondria and cell membrane. And it reduces expression of P2X7 receptor, balance the prostaglandin synthesis, reduces in the inflammatory prostaglandin, and increase the anti-inflammatory prostaglandin, improves ATP and reduces TNFA, and change the expression of interleukins. So it means it reduces inflammatory interleukins and increases anti-inflammatory interleukins. And all of these leads to less neutrophil influx, less capillary permeability, and increased lymphatic drainage, and change the pro-inflammatory mediators. And at the end, we see anti-inflammatory effect and anti-edematous effect of photobiomodulation in lung tissue, and all of this approved by experimental and animal model studies.
Thank you for this slide. This is a very, very succinct and clear sign explaining the benefits of the laser energy on photoreceptors in mitochondria and cells and stuff. Very, very concise. Thank you for this.
Okay. So let's move to next slide. And here we compare the effect of SARS-CoV on lung tissue. In the left, and in the right, you see the effect of laser therapy. And you can compare to see how low-level laser can influence the effect of this virus at multiple levels. So the stage that virus attacks the epithelial cell and send inflammatory signals, at this stage, laser therapy reduces the signal. So these signals increases activated macrophage, but low-level laser specifically reduces activated macrophage. So when we have less activated macrophage, we have less cytokines. It increases the cytokine. and less signaling to activated T cells, activated neutrophils, and decrease in the capillary permeability. And all of this exactly against of things that happening for SARS in lung tissue and in cytokine storm. And when you go in detail by detail of the expression to see increasing P2X7 receptor expression and increasing all of inflammatory cytokine and chemokines, photobiomodulation works against of this. And also we have a bonus here that low-level laser increases ATP and enhanced healing process and reduce the collagen deposition in lung tissue. And at the end, when you compare these together, you notice how low-level laser or photobiomodulation is able work and attack virus at multiple levels. So there is another consideration we need to note about that is patients who hospitalized and they are on long-term ventilator. The problem here is not just COVID and inflammation there. There is that long-term use of ventilator. It leads to ventilator-induced lung injuries. So we have more injuries added to COVID attack, added to the virus and exaggerated inflammation. And there are two experimental over Murine model of lab results that they induced ventilator-induced lung injuries over these animals and used laser therapy or photobiomodulation. And they noticed laser is capable to reduce the injury scores in tissue. So it is confirmed in two studies. And I want you to look at this whole picture that we have here. Virus attack, exaggerated immune system, and long-term injuries of a ventilator. And photobiomodulation can influence all of these three problems at the same time. So this is another benefit that we expect to see from photobiomodulation. So we discussed the basic and the pathogens and their effect. But I'm going to look at this picture with different way. Why adjunct low-level laser therapy could be a solution for COVID-19 pneumonia. So I'm not going to discuss about the pathogens, about the basic, about the molecular level. I know there are lots of researchers working on this. We have great speakers that will discuss about this. But from practical aspect, how we can say that photobiomodulation is a solution. First of all, let's us take a look on literature to see what we have there. We know laser has a strong anti-inflammatory effect approved by meta-analysis. And we know the anti-inflammatory effect of laser therapy is not significantly different than non-steroidal anti-inflammatory drugs, just slightly less than glucocorticoids. And we have different application of photobiomodulation that approved through several meta-analyses. Right now, over 60 years, we are using laser therapy for pain management. We are using for tissue healing, tendinopathy, cellulite treatment, improving lymphedema. So there are lots of applications that already is around, and there are people using that and practicing this, and patients get the advantage of this treatment. And when we look closer about the effect of low-level laser in respiratory tract, we see it's not the first time we are using low-level laser therapy in respiratory tract. In literature review, you find several clinical studies, clinical trial studies, over 1,000 patients in different respiratory conditions: acute pneumonia, chronic pneumonia, bronchitis, asthma, and it has been used in children, adults, and elderly. So we are not the first people who wanted to try photobiomodulation therapy in respiratory tract disorders. Then in veterinary medicine, right now, photobiomodulation is a tool to treat upper and lower respiratory tract conditions in animals like cats and dogs. So we have animal models around there too. And if you want to go a little deeper and dig deeper, we see there are at least 14 experimental animal studies about the anti-inflammatory effect of lung tissue just in ARDS and cytokine storm. So we have enough evidence to confirm that low-level laser therapy could be a chance for COVID situation. And we discuss how laser therapy can work at multiple levels. So we are talking about a modality that is around for 60 years. There isn't any reported side effects. And we are using this modality for different health conditions. And also, it is very available. I mean, we have lots of lasers available inventories in hospitals. Each hospital, when you go, you see there are laser clinic, pain clinics, physiotherapy centers, and they have their own laser set, but we need just adjust with proper parameters and setting to use this device for photobiomodulation. So when you consider and comparing this with other medications, other modality under research right now, you see this modality is very available. And it's very practical just to approach that and use it for clinical trials in this field. And also photobiomodulation is a cost-benefit treatment when you compare with other options that right now we have. You know, a laser device has different price ranging, maybe from 300 to 200,000 or more, but with each laser device, we are able to treat about 20,000 patients based on the lifespan of the diodes. So I'm just making one small compare for one medication is undergoing a study right now in several countries, and there are lots of budget for these research. For example, interleukin-6 antagonists cost $1,000 per injection. Each patient needs 3 to 6 injections, and it costs $6,000 per patient. And when you multiply this over 20,000 patients, you see how much money we need to invest or expend for this treatment if there would be any approval. And just with $10 million, you can imagine how many hospitals you can provide laser for them and make it affordable and available for patients to use that. So I'm getting back to our problem. The problem all of researchers want to solve and find a solution for that. We have COVID-19, it's lethal because of cytokine, because of ARDS, we are short of hospital beds, we have limited ICU bed, we have limited ventilator, and some patients need longer time connecting to ventilator, and there isn't any exact treatment or solution. So in our article and paper, what we did, and based on my experience and the treatment protocol that I had for my previous patients and different studies that I've done, I tried to design a therapeutic protocol. So anybody who wants to practice, they can have this as a guideline maybe, or if they have more guideline, I would love to know and share with them this therapeutic protocol. So from the one point we need to consider is that we can use this modality at different stages of disease. From the beginning symptoms, and then from the time that we have severe symptoms. What we need to do, we need to cover the lung tissue, and the radiation should be from different sides, from front and back side, and even lateral side, to make sure we can reach the lung tissue. You know, lung is an organ in chest cavity, and chest wall thickness is between 2 to 6 centimeters in human body. And based on World Association laser guideline for deep target tissue treatment, we have a dosage recommendation by them. And we are using this recommendation for deep tissue inflammation, like hip inflammation, pelvic inflammation, low back pain, or shoulder. So these are joints located in deeper part and covered with lots of muscles. And when you compare the location of chest with a big joint like hip, you see we have the same barrier over this target tissue. And with proper dosing over surface of the skin, we can reach the lung tissue with the required amount of energy dose that we need to treat lung. And another method of the treatment is blood laser therapy, and I know you're familiar with that, and lots of researchers working on it, and we can apply this blood laser treatment transcutaneously, simply over cubital area, or you can use it intranasal with small intranasal devices and deliver the energy to whole blood.
So both a direct, you're acknowledging a direct effect to the lung tissue and an indirect effect with the blood and the immune and everything like that.
Yes, you're right. As we discussed, laser therapy could be influenced and treated locally and systemically. So we can target our immune system with local treatment directly over damaged tissue, and here is our lungs. And then we can deliver energy indirectly through to systemic effect by blood or through to nasal or transcutaneous treatment. And these both treatments are very easy to apply and practical. And the last word and take-out message from this paper is that based on our discussion, we believe adjunct low-level laser therapy or photobiomodulation therapy can be added to conventional treatment in COVID-19 in different states. And it can, because of its anti-inflammatory effect, it can work at multiple levels, and we expect to see a shortened recovery times, and it may reduce the need of ventilator. And also, if we consider this modality and we see improvement, it could be a significant effect on decompressing our overwhelmed hospitals and healthcare system. And the plan, I believe it's time to act. We have enough evidence through to animal models, through to human reports and literature review that we can use this treatment. We have inventory available, and now it's time to plan clinical trials. I believe photobiomodulation therapy is ready for clinical trials on COVID-19, and it's time to act.
Very good. And you have acted. You have treated people. You have done your job. You have brought these into the ICU. You want to talk about your cases at all?
Yes, actually. So based on this commentary paper that we published, we see there are more clinical trial research coming up. but I'm going just talk a little about the first use of photobiomodulation in COVID-19 patient, as you requested. But before that, let me tell our story, because I really like our story. How did the first pilot clinical trial happen? So I consider this trial is international collaboration. The principal investigator of this clinical trial is Dr. Scott Sigman. Dr. Scott Sigman is an orthopedic surgeon, and he uses laser treatment in his pain clinic. And he observed a profound effect of anti-inflammatory reactions of laser treatment in musculoskeletal injuries. Based on this experience that he had, this idea came to him, okay, why not using laser therapy for COVID-19, pneumonia and inflammation there. So he went to the local IRB, requested an approval for a clinical trial. They asked for FDA guidance, and after receiving the FDA guideline and approval, Dr. Scott, he approached to Monica Manesi. Dr. Monica Manesi is the Italian biologist professor, and they designed the first proposal how to use laser therapy in COVID pneumonia. But the problem was that they didn't have any experience work with laser treatment in respiratory tract. In March, I posted a discussion in ResearchGate platform. I know you know ResearchGate platform. And the discussion was that if how we can use photobiomodulation therapy in COVID-19. And Dr. Scott, during his research, they approached me by this discussion on ResearchGate platform and contacted me and invited me to join them and design a therapeutic protocol for their laser system for COVID-19. So based on the calculation that we did and all of the parameters and technical parameters, we add proper dosing, and I provide evaluation criteria for this study. And later, Dr. Mariano Vitrisi from Canada joined us to collecting data and analyzing data. And this is the story how this clinical pilot trial study happened. And as you see, they are independent researchers from different parts of the world collaborating together to conduct this research study.
So the peer-reviewed case, as you said in the last slide, at the bottom of the last slide, this case that you published on the 57-year-old African-American man with severe COVID pneumonia was one of the people in that group. Was this actually... Was this actually patient 0? Was this like
Yes.
The first one you tested?
This is the first patient. You know, I'm not going to discuss about clinical trial right now because it's under work and we can share the data right now at this stage. But scientific committee of this trial decided to publish the first case because we wanted this report and this message out sooner and earlier than our trial, because you know it takes lots of time to have all of the information, collect and write the article. We wanted this information out. We wanted to send a message, okay, this is the first person that received the photobiomodulation therapy, and these are the results, and we are inviting more researchers to join us, and I hope we see more clinical trial out there very soon, and we can find some results to see if we can use this modality for COVID-19. So this patient was a 57-year-old African-American man with severe COVID-19 pneumonia. Patient presented at hospital with severe respiratory symptoms, with acute renal failure, positive colostrum deficit diarrhea, severe dehydration, and also the history of hypertension and asthma. And as you see, this patient was very complicated patient. And the chest X-ray actually demonstrated the worsening bilateral lung infiltration. Patient needed oxygen 2 to 6 liters, and the O2 saturation was about 80%, requiring admitting in ICU to receive oxygen for 48 hours on 6-liter oxygen. So all of this history shows that the patient was a high-risk patient, and it needed a strong supervision in ICU and maybe predicted intubation and ventilator support. So what was the patient's treatment? So per laser treatment, patient was bedridden with an O2 saturation 22 to 25% on 2 to 4 liters oxygen. Patient completed a course of antibiotics, and he didn't receive any pharmaceutical or any IV support against of COVID-19, just conventional treatment. And the patient failed to respond to physiotherapy trial. After all of this treatment, just patient got worse and worse, and it was the time that Dr. Scott approached to the patient and introduced our trial and told him, okay, we are running this clinical trial, this is our RIB approval, and if you'd like to join to this research. And patient signed the consent, and he wanted to be part of this research study as the patient one. The laser system that we use actually was the laser system that Dr. Scott uses in his pain center, maybe the only laser that was available in that facility. So the laser was an MLS laser therapy from ASA Laser Italy, and FDA cleared multi-wave locked systems. And the system uses a mobile scanner with 2 synchronized laser diodes, 905 nanometers and 808 nanometers, that these 2 laser beam works simultaneously and synchronously. And as I mentioned, doctor uses this laser in his pain center. So this is the first patient, patient 1, and this is the patient's position. As you see in the picture, we use a specific prone position, and we ask patient lay down on tummy and put his hands under his head, as you see, like there, for maximal scapular protection. So we wanted to reduce the barrier from chest wall and make it possible to light penetrate deeper to the lung tissue. So a scanner adjusted about 20 centimeter above the skin based on the manufacturer guideline. And based on the calculation that I did and the therapeutic dosage that we use, we treated each lung for 14 minutes, over 250 square centimeter for each lung, and the total treatment was 28 minutes. So it is a diagram that I made it just to show how we shine the laser from the back side of the thorax. And this is the area of radiation. The diameter was 10 times 25 centimeters, so in total 250 square centimeters. And the dosage was 7.2 joule. 7.2 joule was over the surface of the skin, but when it penetrates to deeper layers and reach the lung, we hope we can get minimum 0.01 joule, the minimum required dose for any stimulatory or any response. And as I mentioned, we consider the chest wall thickness 1.6 to 6 centimeters in human. The number of the sessions, we used once daily session for 4 consecutive days.
Not a lot, not a huge dose, basically. No. Not a huge dose, and no. You're pretty brave to say do it once a day. But did you already put those protocols together of once a day, or did you?
Once a day.
Or was it the findings off of the patient's response that changed it?
No, we did once a day, and I calculate the dosage and the required dosimetry based on my experience that I had with asthma, that how many joule I used. And considering that, for example, with a medium depth of 2 to 4 centimeter of thickness, and we need a proper amount of dosage on surface of the skin to penetrate deeper layer. And we discussed with more detail and some references in the paper. If anybody wants to know how we calculate and we reach that point, we mentioned all of this in our paper. And I know it takes lots of time to explain it here, but right. I'm just going to have a quick review on this case report. So what was the response and what we witnessed during the treatment? First of all, the first session was very difficult for patient. Patient was in very bad health condition and respiratory symptoms, and he had paroxysmal coughing spells, and he couldn't tolerate whole treatment procedure at once. He needed a break, so we stopped the treatment for a few minutes, give him a break, and then we continued the treatment in first session. But what we witnessed was that within 5 minutes, just 5 minutes of the starting of laser treatment, his O2 saturation rose up from 94% to 100%. And following the treatment, patient returned to the bed and resumed in semi-position for the rest of the day, and his O2 saturation remained at 98% for the rest of the day. So it was the response after the first treatment. After second and third treatment, we witnessed and observed significant improvement on respiratory symptoms. Actually, his paroxysmal coughing spells resolved after the third treatment. And after the fourth treatment and completion the last treatment, patient was able actually to discharge to rehabilitation facility. And a day after that, patient was able to complete 2 trail of stairs climbing, and with physical therapy, patient was in the process of weaning to the room air.
Wow.
So it means 4 days we see significant change on respiratory symptoms, on patient well-being, and all of the response that observed step by step. But
Doctor, this seems like a miracle to people who would just see this. On my side, that's about what people have reported when they get better using photobiomodulation therapy, is about 3-4 days, and they've kind of kicked it. Were you extremely surprised by these results, or did you have that already in mind with your asthma people or the pneumonia people that have been treated? What was your take on this?
So I had some background and some thoughts in my mind, because when Dr. Scott started the treatment, I asked him, okay, I want you to record the O2 saturation, and all of this should be recorded step by step. And he asked, could we expect to see some change so soon? But I expected, because I observed and I saw this change in people with asthma, and that is thing happened in 5 to 10 minutes of first treatment. We observed increasing and a rose up in O2 saturation just right away. Then I expected to see some change on chest X-ray. That is why I asked him, okay, for evaluation criteria, we need more objective parameters. In next slide, I'm going to talk about the objective parameters. These are just our explanation, our observation, but we have more here to explain what's happening there. So I've summarized all of the criteria here. I know it looks like a boring chart, but there are lots of information there. Believe me, you will see how it works. So we evaluated patients before and after the treatment, pre-treatment and post-treatment with several criteria. So we used Pneumonia Severity Index, PSI. This is an index kindly predict the morbidity and mortality of pneumonia in patients with chronic conditions like COPD. And how it works, there is a calculator and you need put all of clinical and lab results there, and based on the scoring that the system puts points for each parameters, we find a final point. So pre-treatment, this pneumonia severity index was 142, placing patient in class 5. It means this patient predicted to be admitted in ICU and intubated and go on ventilator support. But when we start the treatment, 4 days after the treatment, when we evaluated the PSI, when you see it reduced to 67 and placed patient in class 2, it means just we need to consider patient as an outpatient and just monitor him. Another criteria is a SMART COPE score. A SMART COPE score is evaluating pneumonia severity, and it's complex score going detail by detail over different clinical and lab and chest x-ray parameters to point and give the score. So it evaluates systolic blood pressure, multilobar effect, albumin level, respiratory rate, tachycardia, patient mental status, amount of oxygen. So there are lots of factors there. And based on the scoring that we had for this patient was in 0.5 and placing patient high risk. It means one of 3 patients at this class need to admitted in ICU, intubated and receive ventilator. But after the treatment, this score reduced to 2 and placed patient at moderate risk. It means 1 of 10 patients expected to admit in ICU. So you see the change that's happening here over clinical exam, over lab results and radiographic, that all of them scored, was scored by a SMART COPE scoring. Another evaluation criteria is Brescia-COVID. Brescia-COVID score is a score that developed by Italian infection specialist and ICU specialist together to provide a step-by-step management for COVID patients. So this is the specific criteria developed for COVID patients. And based on this score, our patient score was 4. It means patient needed a high flow nasal oxygen cannula, and if we couldn't see any improvement, there would be a chance of intubation and transmission to ICU for ventilator. But after the treatment, this score reduced to 0. It means that this level patient just need observation and monitoring. Another criteria that we evaluated is community acute pneumonia score. This score actually is not designed for COVID patient, but this is a score that evaluates patient's aspect of respiratory syndrome. So it is the subjective criteria. The other scores, they are based on clinical and objective criteria, but this score evaluates patients' feedback with a questionnaire form. And this questionnaire form asks about the severity of the symptoms, how patient feels, the well-being, the number of the attacks of cough, and there are more details, and there is a specific scoring. So this score for patient was 36.68 pre-treatment, and 4 days after treatment, it increased to 82.82%, considering that the normal range is 75 to 100%. And you can see even from subjective aspect of this treatment, patient has good feedback and result from the treatment. And then we have Raleigh score. Raleigh score is another score over evaluating the chest X-ray. I'm going to discuss this on next slide. And I'm moving to blood test results. So white blood cells before the treatment was 10.7 and it's reduced to 6.5. C-reactive protein, it's a inflammatory criteria, was 15.1. You see how high was it, and it reduced to 1.23 at normal range. And O2 requirement was 2 to 3 liters after the treatment. It reduced to 1 liter, and 2 days after the final session, patient went into room air, and O2 saturation pre-treatment was 93 to 90%, and it increased to 100%. So these are all criteria from objective and subjective evaluation that we had on patient.
Doctor, one thing about since that's a big thing, could you go back one slide, please?
Sure.
So which of these is going to be your primary outcome? You have a lot of great information. I think anybody that sees one of these would say, wow, the guys in Italy said, well, the Brescia score is doing pretty good, you know, all this stuff. But what's the main outcome, primary outcome measure that you're using for your clinical trial?
So for clinical trial, actually we are using a SmartCope and Brescia COVID because the other, you know, it's a practice. We are just challenging us to see which score shows better improvement or which score has accurate response. And there are some references when compare these different scores, we have higher rank for a SmartCope and Brescia COVID. Okay. So that is why in our clinical trial, we have all of these scores, but based on recent research studies, we decide to have these criteria. Or we are working on that, on data, and hope we could publish it very soon.
The secondary outcomes are going to be great also. I mean, you've covered a lot, you've gathered a lot of information. So again,
we try to collect lots of information as we can, because, you know, we are limited of number of the patients, and we try everything. And one of the things we really wanted to other researchers to be focused on that is blood work and collecting data for C-reactive protein and interleukin-6 before and after the treatment. It's very important to have these parameters. We discussed the level of cytokine determines which patient needed to go ICU or ventilator. And if we can confirm that photobiomodulation has direct result over these blood markers, actually we have a strong voice to confirm our point.
I agree.
Okay, so let's talk about the chest X-ray. This is an objective tool, and there is another score named Raleigh score. Raleigh score actually is a radiographic assessment of lung edema, and it's designed in a way to score lung imaging. So you don't need to be very specific specialist or radiographist to score this, because we want confirm some quality of scoring to quantity scoring. So how it works, that we can, the Raleigh score consider a point between 0 to 4 for each lung. And it refers number 0 as no involvement in lung, and 4 means more than 75% involvement. And then you add the score of both lung to get the total lung score. So right now you can score yourself. So this is radiography before the laser treatment, and we are looking for ground glass opacity here and here, and also consolidation and fluid accumulation. And as you see, the scoring for left lung is more than 75%, I can say 100%, and for right lung is the same, and each score for each lung is 4, and the total raw score is 8 for this patient. And after the treatment, immediately after the 4th session, we have our second chest X-ray, and as you see, we see more than 50% improvement on left lung and about 60 to 70% involvement in right lung. And when you score each lung and add the number together, the total score, raw score for lung after the treatment is 5. So we have 8 before the treatment, and it reduced to 5 in less than 6 days. So what is the message here is that based on the most recent research study published, over 60,000 patients, multi-center over world, the imaging absorption stage for severe COVID-19 typically starts after 14 days, and it stays up to 6 weeks. So wow. This is a result. If you have a severe COVID-19, if you have a white lung, the expected day to see resolving on chest X-ray or CT scan, it would be minimum 14 days. But here we observe this change over 6 days. So at the end, our case report, the first case report, showed positive results of supportive treatment with photobiomodulation. And based on this report, we consider photobiomodulation to be a feasible adjunct modality for treatment COVID-19. And I know it's just one patient, but we need baby steps to start to continue and go forward. And I hope we witness and we see more academic research centers join us and design the clinical trials. And we have evaluation criteria, we have the therapeutic parameters, and we have our inventory available in whole hospitals. And I believe it is low-cost treatment and low-cost clinical trial compared to other ongoing studies whole world, and hope we see more researchers collaborating with us.
No, I just wanted to say one thing when you say it was just one patient, but the reality of it, Mr. 57-year-old African-American and his family are pretty happy that he was just one. Because you know what? The most important patient is me.
You know, I'm considering all of high risk and risk factor for this patient, that he was older than 50, and
African American,
the rate of hospitalization for African American is 3 times in US, and he had history of asthma, a chronic respiratory problem, hypertension, another problem. He showed up with acute renal failure,
and some obesity, heart, go ahead.
Overweight, and also he had severe dehydration and positive COVID test and positive involvement of respiratory tract. So you can see it's not just one risk factor. There were lots of factors together, and positive chest X-ray, higher C-reactive protein. So all of these showed that this case was a very severe pneumonia, and we witnessed improvement in 4 days. I can't say it's a miracle, maybe it's a chance, but if you want to confirm, okay, it's not a chance, we need more trial. If you want to confirm it that I'm wrong, you need clinical trial. So challenge me with any trial that you see to see what's going on, because I believe there is a solution. And at the end, this is our final message and the take-out message. There is an urgent call for pilot studies, for clinical trials, and we need more study to evaluate the effect of COVID-19 pneumonia. It doesn't matter if we see clinical positive results or we see less results or sometimes maybe negative results. So there are lots of blind spots, and the only way to understand and know what are the results is just to dive on and go for it. And I believe there is a light at the end of the tunnel.
I think that you've done a great job at, as I say, elucidating immunity and illuminating us, you know, on this process that you went through. I got a lot out of it, more than you know, before that I could have ever done that. So what am I, just to close up here, your paper is really whipping around the internet. It's showing up everywhere now, and I really appreciate that your time that you gave us. What do you think is going to happen in the future? I mean, you already had an international congregation of people helping. It's got to become, it have to be more. I mean, you're like a pop superstar now, right?
I expect more clinical trial coming up, because after publication of this paper, I have contact from different peoples. I have contact from Brazil, I have contact from India, 2 more states from US, and it shows there is a movement, and it shows people have that strength or find that courage. Okay, it's time to move on. It's not just a theory, and it's not the things that we want to talk it in paper or talk it in the slides and discuss it, the benefits. Because first of all, we use laser for 6 years. There isn't any reported side effects or minimal side effects, and there isn't any costs that we expect higher amount of the budget. And we have used it for different conditions, for pain management, wound healing, hair growth, lymphedema, cellulite treatment, tendinopathy. So there are lots of studies, and we have a strong meta-analysis evidence for anti-inflammatory effect. We have a strong experimental animal study, more than 14 research studies, and I believe right now there are more, because my results was for 6 months ago, and I'm sure there are more coming. And also, we have a clinical application in literature review, over 1,000 patients in respiratory tract. I'm aware of a study in Russia that they did over 30 patients as case series, and they used supportive treatment too for 60 patients, and I hope we see their publication soon. And so, yes, I believe there would be light end of the tunnel.
Thank you. Thank you so much for your great work. Hopefully we can help to get the word out to the other researchers on this group, and to keep the light shining.
Keep the light shining. Hope for that.